The Frequent Hemodialysis Network actually was involved with two separate studies that had similar outcomes and similar protocols. I was a clinical investigator for the Wake Forest site for the frequent daily study, where dialysis was done in center for a short period of time, 6 times per week, on average between 1.5 and 3 hours. And I was also the overall principal investigator for the nocturnal study, where patients did dialysis for 6 nights a week for an average of 30 to 36 hours per treatment. They're two complementary studies. They're both looking at providing much more dialysis than a typical patient does. This is an extension of the hemo study, which showed that more dialysis was not necessarily beneficial on a 3 times a week basis. The thought process of the investigators was that if you do dialysis more frequently, you don't have the same fluctuations in terms of intradialytic weight gains, and the patients accumulate less fluid between dialysis treatments, and at least on a theoretic basis, you would think that that would improve left ventricular hypertrophy, that would help improve blood pressure control, and then with the more frequent dialysis, you also have more removal of uremic toxins, and there could be certain potential benefits from that also. So the study was designed to look at a large number of outcomes. The two primary outcomes were looking at change in left ventricular hypertrophy, and also looking at change in a measure of quality of life called the physical health component. And both of these have been shown in larger studies to be predictive of mortality rates. Neither of the studies were designed to look at mortality. For a mortality study, you would need several thousand patients, and clearly there were not the patients nor the resources to do a study of that size. So these secondary outcomes were chosen, and then there were an additional group of secondary outcomes which looked at areas of interest for nephrologists: anemia management, management of hyperphosphatemia and secondary hyperparathyroidism, depression, cognitive function, and nutrition. The main results for the daily study were published in New England Journal in December 2010, and the main results from the nocturnal trial were published in November of 2011. And for these trials, for the daily trial, there was a benefit in terms of both left ventricular mass and also in terms of the physical health component. The nocturnal trial was a smaller trial, and we saw a decrease in LV mass, but it was not statistically significant. In terms of the physical health component, both arms of the nocturnal trials showed a small, non-significant improvement in the physical health component. And we've discussed why that might have been, and it was thought that the patients actually going home to do the dialysis treatment may have provided a small benefit in both arms of the trial. So even though the nocturnal trial was a negative trial, we certainly learned quite a bit about the nocturnal dialysis too. Both studies, patients who were doing short daily or patients who were doing nocturnal, showed improvement in blood pressure control, required fewer blood pressure medications to keep their blood pressure under control, and also had improvement in treatment of hyperphosphatemia. In fact, the removal of phosphorus in the nocturnal study was so large that some of our patients actually had to add phosphorus to the dialysis so they would not get hypophosphatemia. And there's no other form of dialysis that can claim that larger removal of phosphorus. So certainly there were benefits of both of the more frequent studies. This has to be tempered with an increase in vascular access events. And if you think about doing dialysis more frequently, that means you're using your access more frequently. So one of the concerns was whether patients had more complications with access, and that turned out to be true. So there are benefits for more frequent dialysis. I believe that the clinician has to look at the individual patient, has to individualize therapy, look at the potential benefits of more frequent dialysis, balance those against the risks of more frequent dialysis, and then inform the patient so the patient can make an informed decision. Now, one of the reasons I think there was a difference in the left ventricular hypertrophy between the two studies is that in the daily study, most patients had little to no residual renal function, whereas in the nocturnal study, a fair number of the patients, about 50%, had been on dialysis for less than a year, still had a reasonably a good amount of urine output. And those patients in the daily study who had no residual output were the ones who most often had a decrease in their left ventricular mass over time. So clearly, another thing that we've learned from the study is another reason why it's important to protect residual renal function. We know that residual renal function is important to help improve mortality, but perhaps we understand why that is because residual renal function is preventing that LV hypertrophy. So certainly one of the suggestions is that patients may benefit from more frequent dialysis once they start losing residual renal function to help prevent the LV hypertrophy, which in turn should help to decrease mortality risk. Now this is of course all post hoc analysis of the study, but it certainly from a theoretical viewpoint makes sense that this would be the mechanism of how we're seeing one of the benefits of more frequent dialysis. In terms of the application of the dialysis research to clinical practice, it gets back to the individual patient and finding out what is best for the individual patient. And that's what's so very important about this research, is not only looking at overall trends and what are some benefits and what are some risks of the therapy, but looking at the individual patient and saying, you know, this is a patient who has a very high phosphorus level, so they are going to benefit from more frequent dialysis despite some of the risks that may be associated with more frequent dialysis. It helps us better explain to the patient how they can choose a dialysis modality and what might be the best modality for the patient. So it helps the patient make an informed decision that hopefully will lead to a better quality of life and better outcomes.